Hi, good morning, everyone. Welcome to the meeting of the Adverse Decisions Work Group. Good morning, Chair Beidle.
Good morning, Commissioner Grant.
I think we are at a critical mass of work group members. And I know it is a busy day. So I'm going to open up this meeting and give a little bit of an overview of our agenda and our work today. So for those who don't know me, I'm Marie Grant. I'm Maryland's Insurance Commissioner. And this is our second meeting of this really important legislatively created work group. So we're going to do a few things today. Our first order of business is actually to select our work group chair. The legislation that created this work group specifically requires our work group members to designate a chair. And so I'm going to make a nomination and we'll talk about that. Assuming that all goes smoothly, which I think it will, then I'm going to turn over the remainder of the meeting to the chair. And we're going to hear a presentation from Louis Butler, who's Director of Appeals and Grievances at the Maryland Insurance Administration, who's going to talk about some of the terms and how consumers and providers can address complaints with our state agency. And then we're also going to hear a presentation from the Maryland Hospital Association on their analysis of denials data, which has some really interesting insights. And then finally, we're going to discuss a draft work plan. I want to emphasize this is very drafty. This is not the end all be all. We really, really want, I think, work group member input as well as public input. But I think the important thing about this work plan is it will give you a sense of the timeline that we need to be working on to produce a report in a timely manner. We committed to doing a report by December 1st of this year. Will there be a link for replay? Craig, the recording of this meeting will be placed on the website, correct?
It will.
Okay. All right. Any other questions? And I think if anyone's having trouble at any point with the audio visual or anything like that, Craig I is running the technology behind this meeting and can be helpful. So with that, I want to open it up and actually offer a nomination for chair of this work group, Chair Pam Beidle. Chair Beidle sponsored the legislation creating this work group. I think she has a wonderful perspective on all the different healthcare stakeholders and inputs, but also has a deep sense for how adverse decisions and denials can impact consumers in the state. And so I think, and she has incredible experience and insight in tackling thorny issues like this. And so I just think she'll be a fantastic chair of this work group. Jai, I see you have your hand raised.
I just want to second your nomination. I agree 100%. Thank you.
Wonderful. Thank you so much. So Chair Beidle, do you accept the nomination?
I'm honored to accept the nomination. Thank you.
Okay, wonderful. Does anyone else have any thoughts, or are there any other nominations that we want to discuss for chair before we go ahead and vote? Oh, Zach, I see you have your hand raised.
I would just say I would be great to have Chair Beidle chair this work group. I have worked with the chair for over 10 years in every single role that I've had, including at the MIA. She's an extremely fair and honest legislator who truly does care about these issues. So I think she'd be an excellent choice.
Thank you, Zach.
Okay, any other comments or nominations before we go to a vote? Okay, all in favor, say aye or raise your hand.
Aye.
Aye.
Any
Aye.
Aye.
Great. All right. Well, Madam Chair and Chair of the work group, I am happy to turn this meeting over to you.
Thank you, Marie. I just want to make a couple comments. You know, this work group is so important as we look at the rise in adverse decisions in Maryland. And I was reviewing some of the documentation this morning, and it really has been a significant rise in the 4 years between 2021 and 2024. So I think it's crucial for understanding and addressing the increase in health insurance claim denials. And by bringing together the state agencies, insurers, healthcare providers, the work group, it aims to enhance transparency, standardization, and accountability. So I'm looking forward to working on the work group. I'll be happy when session ends and I have a little more time to work with you on this. But I've seen your work plan, and I think we have some significant work ahead of us. And I look forward to chairing the committee and working with the committee. So thank you for this opportunity.
Awesome.
Thank you so much for agreeing to serve.
So let's see, back to the agenda, I guess, huh? I guess we're going to start with presentation by Lewis Butler. Is that what you'd like for us to do next, Marie? So Lewis Butler is the Director of Appeals and Grievances in the MIA. And we're going to hear an introduction from Lewis and his focus on definitions of diverse decisions versus coverage decisions and how the MIA handles each type of situation and what consumers and providers should do in each situation. When Lewis concludes his presentation, we'll thank him and go on to the next presentation. But Lewis, would you like to get started?
Good morning, and thank you, Chair Bidle. Good morning to everyone, and I appreciate the opportunity to share just an aspect of what we do in the Appeals and Grievance Unit for the Maryland Insurance Administration, just an overview of the MIA Appeals and Grievance process. So let us begin. Work group charges make recommendations to improve state reporting of adverse decisions, including recommendations regarding standard definitions of medical service categories, health settings, adverse decisions, medical necessities, a standard method for categorizing adverse decisions and prior authorization denials, and standardized process for reporting grievances or filing complaints and appealing adverse decisions. Background history of the Appeals and Grievance Law. In 1998, the Appeals and Grievance Law was enacted by the Maryland General Assembly to provide a full and fair process for resolving disputes regarding the medical necessity of a proposed or delivered healthcare service. The appeals and grievance process begins when a carrier renders an adverse decision, which includes a determination that a proposed or delivered healthcare service is not medically necessary, appropriate, or efficient. The member, the member's representative, or the treating provider on behalf of the member has the right to protest this decision through the carrier's internal review process. When a protest is filed with the carrier regarding an adverse decision, this is a grievance. If the carrier again determines the proposed or delivered healthcare service is not medically necessary, the member, the member's representative, or the treating provider on behalf of the member may ask the Maryland Insurance Administration to review the carrier's grievance decision by filing a complaint. Defining terms, coverage decision versus adverse decision. A coverage decision is an initial determination by a carrier or a representative of the carrier that results in non-coverage of a health care service. A determination by the carrier that an individual is not eligible for coverage under the carrier's health benefit plan, or any determination by the carrier that results in the rescission of an individual's coverage under the health benefit plan, i.e., we're looking at section 1510D01 of the Maryland Insurance Article. A coverage decision includes a denial of all or part of a claim, but does not include an adverse decision as described on the following slides. Examples of coverage decisions, basic example could be orthodontics are expressly excluded under the member's contract. Denials based on improper codes are coverage decisions. Payment of an out-of-network claim at an amount lower than the billed amount is considered a coverage decision because it is a denial of part of the claim. Providers or patients may file an appeal with the insurance company about the coverage decision. If the company upholds their decision, the provider or patient may file a complaint with the MIA. Coverage decision versus adverse decision. An adverse decision is a utilization review determination by a private review agent, a carrier, or a healthcare provider acting on behalf of a carrier that a proposed or delivered healthcare service covered under the member's contract is or was not medically necessary, appropriate, or efficient, and may result in non-coverage of the healthcare service. Reference Section 1510A01 of the Maryland Insurance Article. Adverse decisions include a utilization determination based on prior authorization or step therapy requirements. See Section 1510B01 of the Maryland Insurance Article. The member, the member's representative, or the treating provider on behalf of the member has the right to protest this decision through the carrier's internal review process. Defining terms, medical necessity. When a carrier issues a denial, it must state in detail, in clear, understandable language, the specific factual basis for the decision, referencing the specific criteria and standards, including interpretive guidelines on which the decision was based. The decision may not solely use generalized terms such as experimental procedure not covered, cosmetic procedure not covered, service included under another procedure, or not medically necessary. Can AI be used in claim denials? Currently, AI may be used to approve requests and payment of claims, but not for denials based on medical necessity. Section 1510B05.1D of the insurance article prohibits AI from denying, delaying, or modifying healthcare services. The insurance article requires that an adverse or grievance decision be made by a human physician with specified qualifications. Under Section 1510B07 of the insurance article, all adverse decisions must be made by a licensed physician or a panel of appropriate healthcare service reviewers with at least one physician on the panel. How the appeals and grievance law works. The appeals and grievance law gives MIA the authority to contract with 3 independent review organizations to review these medical necessity complaints. When the MIA sends a complaint to an IRO for review and the IRO assigns an expert reviewer for the complaint, Maryland law requires the reviewer to be an unbiased provider in the same specialty as the area or areas appropriate to the subject of review. The MIA's final decision on the complaint may be based on the opinion of the IRO. If the complainant remains dissatisfied with the MIA's decision, he or she may make a written request for a hearing to challenge the MIA's decision. Carriers do not have the right to an administrative hearing, but may file a petition for judicial review with the circuit court. Generally, you must file with the carrier first before you can file a complaint with the MIA. However, in some cases, though, including, for example, when you have a compelling reason, you may file a complaint with the MIA first. Jurisdiction of the MIA's Life and Health and Appeals and Grievance Unit. Jurisdiction means the MIA has the authority to regulate these entities and individuals, including investigating complaints. The MIA has jurisdiction over all commercial, fully insured health benefit plans and HMOs authorized or licensed to conduct business in Maryland. The MIA cannot address complaints or inquiries involving insurance contracts which are not regulated by the state of Maryland. Generally, this includes the following: self-funded or self-insured employer plans, medical assistance, Medicaid, except for delayed payments, Medicare or Medicare or Medicare HMOs, federal employee benefit programs, uniform services family health plans, and contracts issued or delivered to the policyholder in another state. What the consumer needs to do to receive assistance from the MIA. Complaints may be filed online, mailed in, or fax. Fax or mail your complaints to the Maryland Insurance Administration, attention, Consumer Complaints Investigation, Life and Health / Appeals and Grievance. 200 St. Paul Place, Suite 2700, Baltimore, Maryland, 21202. Fax number 410-468-2260. That's for our Life and Health Complaints Unit, or 410-468-2270 for the Appeals and Grievance Unit. Forms to the forms to file a complaint are available on our website. That would be www.insurance.maryland.gov/consumer/pages/file complaint-ASPX. What a consumer needs to do to receive assistance from the MIA. Online complaint portal. We have a portal available. That would be the enterprise.insurance.maryland.gov/consumer/consumer portal welcome page.ASPX. If you have a disability and need to file a complaint by phone, you can call the MIA at 410-468-2244. For appeals and grievance complaints, the patient's signed consent is always required. What a consumer should expect as part of the MIA's complaint process. You should receive an acknowledgement from the complaint within a few days. The acknowledgement letter will include the contact information of the MIA's investigator to whom the case has been assigned. You can call the investigator at any time if you have questions. Appeals and grievance complaint investigations are concluded within 45 days unless an extension of an additional 30 days is granted. Adverse decision data reported to the MIA. Carriers submit self-reported adverse decision data on a quarterly basis to the MIA. The quarterly appeals and grievance report received by the MIA only contains data from commercial, fully insured health benefit plans. The self-reported data submitted by carriers concerns only denials wherein the carrier conducted a utilization review to determine medical necessity. Carriers must provide the MIA in accordance with the commissioner's report and instructions, carrier reporting -form.pdf. In the reporting that the carriers provide to the MIA includes the following: total number of enrolled members as of the last day of the quarter being reported, entities to health care benefits under a health benefit plan issued or delivered in the state of Maryland by the carrier, total number of clean claims received for reimbursement processed by the carrier under a health benefit plan issued or delivered in the state of Maryland, total number of adverse decisions issued by the carrier, up to the 5 most common procedure codes for adverse decisions, the total adverse decisions issued and grievances filed and outcomes, up to the 5 most common procedure codes for adverse and grievance decisions, the number and outcome of all other cases that resulted from an adverse decision involving the length of stay for inpatient hospitalization. New data 2025 includes aggregated zip code data, data not included, granular details about what stage the coverage decision was denied. Carrier codes or categories of service. Carrier codes their adverse decisions and grievance decisions into one of 12 category service that are determined by the MIA. Those categories are inpatient hospitalization, emergency room services, mental health services, physician services, the combined categories of laboratory radiology services, pharmacy services, the combined categories of PT, OT, ST services, including inpatient rehabilitation, skilled nursing facility services, durable medical equipment, dental, home health services, and the combined categories of obesity, IVF, podiatry, hearing, and vision. Categories of service, the 12 categories of service was established by the MIA based on the sort of complaints that the MIA received on a consistent basis. Additional categories can be added as necessary based on complaint trends. Medical necessity and emergency appeals. We have a hotline. 24/7 staff is available to receive medical necessity complaints after hours and during weekends. That number, 1-800-492-6116. Contact information. You can contact the MIA, the Maryland Insurance Administration, at the following numbers: 1-800-492-6116, 410-468-2000, 800-735-2258, and at insurance.maryland.gov. Contact us on social media. We're on all of the various platforms. You Google Maryland Insurance Administration, and we are there. We're ubiquitous in that regard. Any questions? If there are no questions, I thank you for your time.
Mr. Butler, thank you for your presentation. It was very helpful. I don't see any questions. Good job. We are going to now move on to a presentation by Patrick Carlson and Brian Burkholder from the Maryland Hospital Association. And I've had the pleasure of working with Patrick when he was counsel to the Finance Committee. So I'm pleased to see him in his new role. Well, it's not that new now. I guess it's 3 years. So Patrick, thank you for the presentation, and we'll look forward to hearing from you and Brian.
Thank you. Thank you, Chair Beidel. It's a pleasure to be working with you in this work group, and I had to have the opportunity to share some information that we have on denials through some of our analytics. You know, as many of you may know, hospitals have been reporting information to the HSCRC on denials, and this is an effort that's ongoing. But you know, I think it's really been an area where we've seen a lot of progress, and we're getting a lot more comprehensive data, you know, on what's happening with denials, and it's revealing some very important trends for our attention. And so I've got my colleague Brian Burkholder here, who's our Assistant Vice President for Healthcare Analytics, who can talk about some of our analysis of the HSCRC data and what we've seen that will hopefully really provide some important context for the work of this group. So Brian, I'll turn it over to you at this point.
Yeah, thank you, Patrick, and thank you all. Good morning. I hope you all can hear me and see my screen, and we'll get into it. So like Patrick said, we've had a good relationship with the HSCRC, who has provided us the data that they've been collecting for a few years now on denials sent to them directly from the hospitals, and wanted to just kind of share what we're seeing at a big picture level. And so where we wanted to start was looking at really talking through the fact that denials create several different challenges. I think the obvious one that we all know is the financial challenges, but there's other challenges as well. And so what we've done on this slide is just kind of captured a big picture, the fact that yes, denials are on the rise, and that growth has accelerated in recent years. But there's also potential impacts to patients and providers. I think that middle section is important to mention here, which is that we've heard several instances of how the increase in denials has had a negative impact on both patients in some instances. We have a slide later that talks through 2 patient stories and discusses how that might have affected patients, but also providers in several ways. One of which being that they sometimes have to have peer-to-peer calls, which take time out of their day. But there's other impacts as well. And so it's not just a financial issue, but there's really a whole hospital issue here. And what we've heard from our members is that there's a need for more payer accountability. And so we're trying to look through the data and see what the trends are and understand how this can, what we can do with the information that we're just now really for the first time being able to capture now that we have a few years of data to be reviewing. And so I know that Lewis did a great job earlier of going through some definitions. I won't belabor the point. One thing I'll call out here is that when we say a denial, what we're really meaning is any claim that has a part or whole denial. So even if a part of a claim is denied, we are calling that a denial here. That's sort of the industry standard from what our members have said. And then we have some other definitions here I won't go through individually. On the next slide, we also specifically call out what adverse decision references, which is essentially a subset of total denials. It's I won't read it word for word, but it's essentially medical necessity denials by a private review agency or a carrier or healthcare provider, or acting on behalf of a carrier. So it's kind of represents part of the whole picture that we're capturing within our all payer look at things. So let's just start looking at the big picture numbers. This is just total denial dollars from FY19 to FY24. And you can see that there was a little bit of a dip for 2 years, and then it's been increasing since then. The total denial dollars for Maryland hospitals in FY24 was 522 million. And then we've broken out that 522 million in that green box on the right. So you can see how that breaks out by payer and by patient setting and by denial reason. A lot of numbers on this slide, but you can just kind of get a sense for what are the big, what payers and what patient settings and what denial reasons are making up the majority of those denials. The increase from FY19 to FY24 was about 47% in total denial dollars. And if I can direct your attention to at the bottom where it says 51% were medical necessity denials, the next slide takes a look at that number a little more in detail. So 51% across all payers and across all patient settings, that's the total number. But then what we wanted to do was take that same 51%, which you'll see repeated at the top in these dark blue bars, but then break it out by payer on the left and by patient setting on the right. So this gives a sense of, okay, well, if it's 51% overall, how does that 51% break out, and which payers and which patient settings have higher than 51 or lower than 51% medical necessity rates? So this shows that for Medicare Advantage plans, medical necessity makes up a larger percentage of their denials. 64% of all Medicare Advantage denials are medical necessity. And then on the patient setting side, medical necessity denials are much more prevalent in the inpatient setting, much less on the outpatient setting. On this side, we wanted to just show some big picture numbers just to get a sense of the magnitude of kind of and the scope of what we're talking about. So we've broken it out between inpatient, outpatient, and emergency. Again, this is all payer, but about 1 in every 8 inpatient claims has a denial on it. And this is FY24 data. You can see the total quantity and total dollars of denial, some of these same numbers we saw on that first data slide. And so the average inpatient denial ends up being a little over $4,000. It's obviously much less on the outpatient side and even less on the emergency side, but still across all settings, it's anywhere between 1 in 7 and 1 in 10 claims have a denial, pretty consistent across the 3 settings. So what we wanted to do here was show how the trend is over time. Here we've cut it down to just a 4-year span from FY21 to FY24. That's what these 4 different gradients of blue represent. So FY21 is the lightest blue through to FY24 being the darkest blue. So we've done that 4-year trend, but we've also split it out between the major payers. And so now we can compare sort of the magnitude between payers, but also the trend within each payer. And so you can see that Medicaid MCOs represent the most dollars of denials. And they had quite a sharp spike in FY23. That would be between those middle 2 bars. The commercial side is the second largest dollars group, and they had a pretty large increase in FY22. And then you can see the other categories at the bottom. One thing that this slide it can be improved on, what we've done on the next slide is say, well, okay, this is just total dollars, but this does not account for the fact that some of these payers have had increasing volume or decreasing volume over this time. So Medicare Advantage specifically, that trend looks like it's going up, up, up on this slide. But we also know that Medicare Advantage volumes have been increasing, so you would almost expect the dollars to increase. And so what we've done on the next slide is the same view, except now instead of looking at total dollars, we're looking at dollars as a percent of charges. And so this is attempting to account for the fact that of volume changes. And so even if your volumes are increasing, well, that would make your total charges increase as well. And now by looking at it as a percentage, we're getting, I think, a more accurate picture. And so what we're seeing when we look at dollars as a percent of charges is that a Medicaid MCO and Medicaid fee-for-service are now the two highest groups, and that there's still an increase in Medicare Advantage, for instance. It's not as prominent as it was on the last slide, but even accounting for the volume increase there, even accounting for the total charges increase, we're still seeing a denials increase in Medicare Advantage and similar trends in the other categories that we talked about. Maybe I'll just stop there, but I don't want to wait till the very end to ask for questions. Are there any questions so far before I keep going? I think,
Dr. Zama,
yes, thank you.
Dr. Zama, do you need to unmute or?
Yes, sorry.
That's
Good
okay.
morning. Thanks for this the detailed explanation. One question I had is with regards to like the MCOs, they get lumped as one. And is there like a breakdown of these MCOs? Which ones are the ones that are denying the most? Likewise, the Medicaid fee for service as well, which are the ones that are impacting this? Because I feel that some of them, they do deny more than others.
Yeah, thank you. That's a great question. And we do have some of that detail. We've only included a little bit in this presentation. We have more in our detailed denials database that we have access to. We definitely do see that there are variances between Medicaid MCOs and Medicaid fee-for-service providers, same with commercial, but there's not a consistent rate between all of them. And certainly there's some pretty big variances. So that's a great question. We do have that detail. I don't think we included too much of it in this presentation for today in an effort to keep things concise and not try to go too granular. But yes, that's a great question, and we can talk more about maybe internally how we can get that information out going forward. So thank you.
Thank you, Brian. And Dr. Dixon?
Hey, good morning. I just wanted to know if these dollars were based on, if you could categorize where the denials were for these dollars. Are these denials based on medical necessity, or are these more administrative issues? Do you have that data?
Yeah, thank you. That's a great question as well. We do have that data. The slide we're looking at now is just all denials lumped together. In some later slides, we'll call out just medical necessity specifically, and I think we have at one point we have a breakdown of how the different denial reasons kind of split out. So we wanted to just look at it at a big picture first, but yes, we do have the denial breakdown of reasons. And I mean, I can just say the big picture there is that we're seeing increases in almost all reason types, although medical necessity has seen the largest increases of late. So that's sort of the headline. But yeah, we do have some of that detail that I think we'll present in a few slides.
Thank you. We have Jai, you want to ask your question?
Thank you, Madam Chair. Brian, thank you for the presentation. I just had a quick question. I think it dovetails off of Dr. Dixon there. Does this include denials for people that may not have been eligible on a given date of service?
Yeah, eligibility is one of the groups that does get included here. When we break this out on later slides, we just have an other bucket that gets included in our other bucket. I don't have the exact percentage in front of me. I know that is not one of the highest 3 or 4. That is not one of the denial reasons that makes up the top 3 or 4, but it certainly makes up a significant enough percentage But yeah, that is included in our other bucket, the other bucket on the slide we're looking at currently means other payers, but in future slides, when we look at breakdown of the denial reasons, it gets lumped into other, but that is included here.
Yeah, I think that's an important aspect for us to understand because of the redetermination effort that went on with Medicaid over the last several years. As I'm looking at this fee-for-service data, I'm just wondering if maybe eligibility is driving some of those numbers. In follow-up, the other question I have is whether or not the dollar values track with rate increases and charge increases by hospitals. Is it adjusted for that?
So when we're showing like total dollars, we're just taking pure dollars. A
Okay.
slide like this does attempt to account for that by taking it as a percent of charges, so that if they rose together, you would not expect to see an increase unless there was a true increase in the percentage of denials. So the raw dollar slides are not adjusting for any sort of rate increase or inflation or anything like that. But we do have several slides like this that are attempting to kind of counterbalance that increase.
And the last question is, does this data reflect what ultimately might happen if the claim is appealed and ultimately paid? Do you back out that dollar value, or does it remain in the denied bucket because it was initially denied?
Yeah, great question. So these are final denials at the time the data was sent to the commission. So if a denial was appealed and backed out, that would not be reflected in the denials dollars here. There's always an asterisk, which is that some claims take months or even a year or more to go through a long appeals process. And so maybe at the time of submission, it was still labeled as a denial, even though later on it was, appealed and brought back in, although that would make up a small percentage. So that wouldn't really have too much material impact on the data we're showing.
Thanks, Brian.
Yep.
Brian, do you keep statistics on how many of these denials are reversed?
Yeah, it's a great question.
Doctors about the work, they're always having to reapply. So you have those details.
Yeah, we have a little bit of data on that. That's one of the areas where we're hoping to be able to capture more. And I know that one thing the commission is doing is that they've been in talks for months now, and they continue to be in talks about how they can increase and expand their denials collection efforts going forward. They're currently only asking for a pretty small set of data fields and metrics from the hospitals. And so we're a little limited in what we can see from that data. They are planning on expanding the amount of data and types of metrics and fields that they're requesting from the hospitals, which would include things like you're talking about. So we have a little bit of information on basically our data set has negative numbers in it when a denial gets appealed and reversed, so we can count those and look at those. And we've seen from other sources, other reports, how high some of the overturn rates are. But in the raw data, we don't have enough granularity to report in too much detail on that topic.
Thank you. I see a question from Commissioner Grant.
Thank you, Madam Chair. Or maybe just a comment to build on some of what Jai said, and then I think there is a comment in the chat about Medicaid fee-for-service. I don't see anyone from Medicaid on today, but as we talk about the work plan, I think we're gonna hear from them. And my recollection was similar, that this Medicaid fee-for-service bucket may be bigger for reasons that have more to do with eligibility. So we'll definitely be sure to loop the department and Medicaid in to talk more in the future about what might be driving that those high numbers.
Yeah, thank you. And we've heard that as well, anecdotally, that that could be a part of why these Medicaid fee-for-service bars are so high. So maybe we should put an asterisk on that one as well.
Great. And I'm sorry, I said Medicaid wasn't here, and I do think Dr. Dixon, sorry, Dr. Dixon, if I spoke over you there. I don't know if you want to.
No worries.
Yeah. Anything you want to add from the Medicaid side?
No, for fee for service, those are usually reviewed. Some of those are reviewed in-house and some are reviewed by our vendor. So I can get more information on that and bring it back to the group.
I see a question too in the chat. I'm not sure if we've answered this. Do you have data on denials of primary care services versus behavioral health services? Wondering if behavioral health is impacted differently, especially mental health versus SUD.
Yeah, thanks. So we do have some behavioral health data. One of the things that we are hoping to get more detail on, and that the HSCRC is looking to collect more detail on, is being able to break out these services by service line. That's not something we can currently do. So right now, our only way of measuring behavioral health denials is if the plan is a behavioral health plan. And in the data that we have questions about whether that's truly capturing all of it or not. So we do have some behavioral health data. It would be, included in our data set, but it is difficult for us currently to get an accurate count of how much of this is behavioral health. That would probably come in the next step after the HSCRC expands their collection efforts.
Thank you. Dr. York?
Thank you. Are there fines for inappropriate denials, and are the fines large enough to be more than just a trivial cost of business for the various carriers and organizations?
Yeah, that's a good question that I'm not sure I have the answer to. We've heard anecdotally some some answers to that question, but that's probably not enough to report on this call. We've heard of fines before, but yeah, I don't have a sense of the magnitude or how much of an impact that really has on the carriers. So I'm not sure I'm in a position to answer that one.
I think Commissioner Grant may have an answer for us.
Well, a little bit of an answer, Madam Chair, is for the fully insured commercial market that I regulate, we can charge up to $125,000 per violation, depending on the type of violation. So I will say that most of our fines are lower than that, but we do take these types of complaints and denials very seriously, and they can and do result in orders against our insurance companies. So whether that changes behavior, I think, is another question for the companies themselves, but we do have pretty significant authority in the space for that portion of the market.
Megan Mason, you have a question?
Actually, I just wanted to add on to what Commissioner Grant was saying. I work for Commissioner Grant as the Associate Commissioner for Life and Health in the state. And in addition to fines, we also typically order that the claims be paid. And then there are also, there's language that it has to be paid with interest. And that's calculation is kind of set out in the law. But that is in addition to our ability to fine them, just so you know.
Thank you. I don't see any other questions at this point. Brian, do you want to continue?
Yes, thank you so much. So what we've done on this next slide here is, instead of showing 4 bars of different years, we've just shown from 19 to 24. The light blue is 19, the dark blue is 24. We can see the increase broken out by inpatient on the left, outpatient in the middle, and emergency on the right. For what this slide is doing for the first time is looking at the top 5 commercial payers in Maryland. So this is commercial only, and it's 5 payers individually. You can see each graph goes Care First, then United, then Aetna, then Cigna, then Kaiser. And so what we're seeing here, and then one more thing to note is, again, this is dollars as a percent of charges, not just raw dollars. So we can see where the largest increases have been and the magnitude compared to each other. And so the big picture takeaway for us was that across all 5 of these payers and across all 3 patient settings, there have been increases. So all 15 sets of bars have increased from 19 to 24 that we're seeing on this slide. Denials dollars as a percent of charges, some more than others, some payers more than others, and some settings more than others. Certainly inpatient and outpatient are much higher than in the emergency room, but that we're still seeing increases really across the board. So we've been asked before, where are these denials increases happening? And the answer is everywhere, but certainly still some places more than others. And depending on the specific payer, some payers have seen large increases in one setting, but not others. But just wanted to lay out these data as well. And so one thing we've been asked about before, maybe I'll go back one slide. On the right side here, so we're looking at commercial denials in the emergency room. We've been asked about that. It is a relatively low overall rate and a relatively low percentage of all denials. But the next slide sort of just adds more detail to that graph on the right. And so We're looking specifically on this slide about commercial denials in the emergency room. They only make up about 5% of all denials, and they only make up even less than that, 1.5% of all denials dollars. The majority, or almost half of denials in the emergency room are for medical necessity. And then there's a rather large other bucket. You can see at the bottom some of the things included in other: missing information, out of network eligibility issues, duplicate claims, and more. And then we also wanted to show that when you break this out by payer, you can see very specifically that certain payers have had large increases from 19 to 24 in commercial ED claims with a denial, specifically for medical necessity. So the numbers in this graph on the right are a little different than the last graph on the last slide, because now we're looking at just medical necessity in this bottom right bar chart. And so medical necessity denials have really been the ones to increase the most and make up almost the entire increase that we're seeing in commercial ED increases just from the medical necessity side. One thing we've done on this slide is the same thing as 2 slides ago, but instead of showing 5 separate commercial payers, now we're showing 4 Medicaid MCO payers. So this is the same look, except now we're looking at these 4 separate Medicaid payers instead of the 5 commercial payers. And while there's not increases across the board, there are some increases, some decreases. There have been consistent increases on the outpatient side. That's the graph in the middle. But certainly not the level of consistent increases we were seeing on the commercial side. What I will mention is that these graphs are at a different scale. So you can see all of these y-axes go up to 16%. A lot of these bars are going up to 5, 6, 8, 10, 12, sometimes even 14% high. If I go back 2 slides, we'll see that this y-axis was much lower. All of these bars are less than 4%. So even though these increases are happening more, and we're seeing very consistent increases on the commercial side, the overall denial dollars as a percent of charges is still much lower than it is on the Medicaid side here on this slide. So Medicaid is denying at a much higher rate, whereas commercial is seeing more consistent increases. What we wanted to talk about next was the fact that
Can you just
I
go back
mentioned.
one slide, Brian? I'm sorry.
Sorry, yeah.
I just want to point out AmeriGroup is now WellPoint.
Got it. So we should probably change that name on this slide, huh? Okay, we'll make a note of that. Thank you. Okay. I mentioned on our first slide that there's other impacts to denials. We've been talking a lot about dollars on this whole presentation. Of course, that's a key focus. But we wanted to add one slide just to talk about the workforce impact of denials. A national report estimated that each denied claim can cost a hospital or a provider between $25 and $181 to correct and resubmit. If we just take sort of a middle point there, $100, and multiply that by every denial that we've seen in FY24, that would add up to about $56 million in rework expenses collectively for the hospitals in Maryland. So, there's really a workforce impact as well, and that's just the FTEs and the staffing requirements needed to help resubmit and correct and sometimes appeal these denials is not insignificant for a lot of our hospitals. And in that bottom bullet in the red staff time section, we've actually had one hospital system reach out to us and send us data that said that the staffing that they have that has something to do with denials has increased 36% in the last 4 years, and 17% increase in purchase services related to denials. So they've had to spend more internally on both staff and purchase services on related to denials as well. So it's, there's definitely an impact here that's not being captured in just the pure denial dollars on the workforce side of things. Another impact we mentioned earlier was potentially on the patient. So here we have 2 patient stories. We've actually received quite a bit more than these 2. We didn't want to have bog the slide presentation down with too many of these, but to quickly go through these 2 on the left, there is a prior authorization denial. There was a lymphoma patient who completed chemotherapy, was ready for radiation treatment. Their radiologist suggested proton therapy treatment, which is a newer, more precise type of radiation treatment. because the sensitive target area was in the neck and there were better long-term benefits. But this was denied. The commercial payer in this case said that they would, of course, cover more traditional radiation, but they denied covering this more advanced, newer proton radiation. And then the patient and their radiologist had to have discussions. The radiologist had a peer-to-peer call with the payer and essentially deciding whether to appeal this, how much to fight for this. Should they keep trying to get the proton radiation therapy treatment? But this was delaying treatment. The patient should have started treatment a week or two earlier, but there was so much back and forth trying to get this proton radiation treatment approved that actual treatment was delayed, and they ultimately decided on just traditional radiation, not the more new advanced proton radiation, just so that they can get it started, because obviously time is a big factor in instances like this. So that's one. And then on the right side, we have a patient, in this case, it's an MCO denial for medical necessity. A patient presented with active suicidal ideation and intent. They failed to meet the medical clearance for admission to a locked behavioral unit, which you would normally think this patient would go to a locked behavioral unit. But in this instance, this patient needed an essential use of a CPAP machine for obstructive sleep apnea. And so the clinical staff all met and the acute medical staff met, and they all unanimously agreed that this patient needed to be seen in a medical unit, not what you would expect as a behavioral unit. And because of that, this claim was denied. The MCO denied basically the setting that the patient was received treatment in. They said that it was the MCO's opinion that only a behavioral health unit would have been appropriate and approved. But this claim was denied because of the fact that the patient was seen in a medical unit, not a behavioral health unit. So, these are just two of many examples that we've seen of how patients can be impacted and how the staff can be impacted on their decisions, where unfortunately in some instances, what the clinical staff feel is medically most appropriate does not match what they think will be approved from the payers. And I think this is my last slide, so maybe I'll just quickly talk through this one and then I'll take more questions. And that is that there's several factors here. We've heard a lot of anecdotal factors from our members, and we've seen some in the data. Tougher prior authorization rules. We've heard that from almost unanimously across our payers. Our payers continue to tighten the requirements for prior authorization, especially for expensive treatments and diagnostic imaging and elective procedures. As we've mentioned several times, there's been an increase in medical necessity denials. And we've heard anecdotally that the payers are using AI more, never to just directly deny claims, but to assist in identifying claims that might be fit for denial. And then also out-of-network services face extra scrutiny as well. These are just some of the factors that we believe are leading to increase in denial rates. So with that, I'm happy to take more questions.
Thank you, Brian. Let's start with Kimberly Camerata.
Hey, thank you, Chair. Vital, I was gonna sort of comment as opposed to question on sort of two of your last two slides, the patient impact and sort of the cost to the provider. I am the director of the Attorney General's Health Education Advocacy Unit, and so we assist consumers in appealing claims denials, but we also assist consumers who have medical billing disputes with their healthcare providers. And just in the last month, we've received complaints from consumers whose providers are now charging administrative fees, flat administrative fees, to try to combat the costs of these denials, prior authorizations. And in one case, it was a gynecology practice that's now charging everyone a flat $50 fee to try to recoup the costs of these denials, which that fee is largely prohibited by carrier provider contracts and legally shouldn't be passed on to the consumer. And we're addressing that with the provider. But when you talk to these providers, they're just beyond frustrated because of the cost of having to seek prior authorization to, challenge the denials, et cetera. So they're including other things that are really inappropriate. So we are seeing that has become sort of starting to become a new normal for us, and we're addressing it with the provider, but it's certainly indicative of the underlying problem. And is passed on to consumers, which we're, again, should not be, but at the moment it is. So I just wanted to alert you to that.
Thank you. Dr. Jacobs?
Thank you so much, Chair. Brian, you had indicated, I think at one point in the presentation that MHA was looking to collect additional data from the hospitals on a service line basis. And I think that some of the importance of that was you kind of outlined in the previous slide that you focused on some individual anecdotes and case studies about the impact that the prior authorization denial can have. Do you have a sense of when that additional data will come in to you all, and when we could expect additional analysis by?
Yeah, thanks. So I know that the HSCRC is convening they've had several work groups so far to work with hospitals to understand the denials data a little bit more, some of the intricacies of it, so that they can make sure that when they do expand their denials collection efforts, it will be as accurate and make as much sense as possible. They have another one of those meetings coming up in a few weeks. We will be a part of that as well. I haven't heard an exact timeline on that. I know that they are prioritizing this and they understand the importance of this issue. The big question that's still outstanding for us is that when they do expand their collection efforts, are they going to ask for hospitals to resend all their historical years of data with the expanded fields, which would be really important. I think that's the plan, but I can't confirm that or not. So I believe that after this next work group that they're holding to try to understand how the best way to expand their collection efforts, which is in a few weeks, I think that they're trying to implement the actual changes. I don't want to speak for them, but I would think in the next few months after that. And again, the big question is, will they only change the collection efforts going forward, or will they ask for the hospitals to send the past 4 or 5 years worth of data with these additional fields like a service line? We don't know the answer to that yet, but we're happy to pass that along as soon as we know it.
And I'll just affirm what Brian was saying. I think if we, start to think about where the opportunities are, certainly having more enhanced line of sight or transparency into the denials data is really going to be important for all the things that came up. Is there a service line trend? Is there a service line? Can we collect data on a service line basis? But also, can we get more granularity into the reason for the denial, and then capture some of the reversals, that was raised. And so I think, I think that would be an excellent place for us to make progress in enhancing transparency, and then maybe even getting to the point where we have presentation of some of this data on a public data dashboard, so that we really can have sort of an ongoing environment where we can track some of this data.
Thank you. That's super helpful. And now it's making sense that this is the HSCRC data collection effort that you're talking about. And we at MHCC this year we're getting some information about which claims are subject to prior authorization as part of the APCD, the Maryland Patient Care Database. And I believe we should have that data come June or July this year. So we can also circle back around, and potentially in the future, collecting denied claims is something that we could do on a more systematic basis that could potentially be synergistic with what HSCRC is up to. So yeah, because that service line information is important, because otherwise we can't, they're denying on the basis of medical necessity, we would need to be able to actually evaluate if it could be appropriately denying on the basis of medical necessity, but we would need to look at the medical necessity criteria of that specific service. So thank you. That's helpful.
Dr. Jacobs. Dr. York?
Yes, thank you. So what percent of the entire healthcare spend are we talking about that is under the purview of the Maryland Insurance Administration, such as we mentioned earlier, there's a lot of federal programs and perhaps ERISA that are not covered. Are we talking about half of the overall problem, or just kind of what's your gross estimate?
Madam
see.
Chair, I'm happy to
Yeah.
answer that. I think the answer is it depends, Dr. York. So I think for the commercial market, in terms of the medical necessity denials, we regulate about a third of the commercial market. So just under 1 million Marylanders. And I think I could probably talk for hours about that's a steadily declining number. There are reasons for that. But yes, it's for that portion of Marylanders, we have a lot of protections, but it is only a third of the commercial market. I will say that our Medicaid MCOs are also subject to some of our laws, so not necessarily the adverse decisions and medical necessity that our commercial insurers are subject to, but they are subject to clean claims laws and sort of general rules of the road around provider payment and denials.
Ryan, do you have a question?
Thank you, Madam Chair. Yes, I do. Brian and Patrick, thank you for the excellent presentation. It's very helpful in understanding the world of denials from the MHA's perspective. I did have a question about whether or not, in alignment with Mr. Butler's presentation, you guys have data on adverse decisions, since this is, primarily focused. Your data is focused primarily on the denials. Do you have a bucket for adverse decisions in accordance with the definitions we heard earlier?
Yeah, thank you for that. So we can get an estimate, but it's never going to match exactly. So we can filter on commercial payers and we can filter on medical necessity denials, but we don't have enough granularity in the fields available to us. Again, there's just not that many fields to be able to get to the exact definition of what makes an adverse decision denial. So we've tried and we've looked at how the magnitudes kind of compare. They're in the ballpark of each other, and we certainly see that the trends match. So in data reported from adverse decisions, we've seen that generally the increases and decreases are of relatively the same magnitudes, but we don't currently have enough detail in our fields to be able to get to exactly what constitutes adverse decisions.
Thanks, Brian. One follow-up question, and it has to do with, I know in your presentation you had indicated that the use of AI was something that was concerning. And I had a similar concern, but it was on the other side, and whether or not you have any information related to the use of AI systems on the hospital side, and whether or not hospital systems in Maryland specifically, are using AI to improve their billing and their revenue.
Yeah, thank you for that question. We have not heard much about that. We actually are internally, for other purposes, looking more into our hospitals' AI usage, just not necessarily for denials, but really for anything, and we're trying to understand that better. We have not heard that Maryland hospitals are using AI in billing that would affect these denials, but I don't really have the information for that, so I can't really respond to that one today.
Okay, I know that it's something we're monitoring. I know there's been a national trend where there's been an increase in that. There's been independent papers written about it. So I'd be very surprised if we weren't using it here in Maryland. And then the last question I have is whether or not you can speak to the impact that denials have, and I am speaking about denials, on the global budgets that hospitals have, and whether or not hospitals are still meeting their global targets across the years.
Yeah, thank you. What we've heard from our members is that the increase in denials is not being accounted for in their increases in global budgets. When they receive their annual payment updates every year, there's not a denials field. There's no adjustment for denials. So denials increasing is sort of coming directly out of the bottom line, if you will. And if denials doubled from one year to the next, there would be no other way to make up that money. It would just come out of the hospital's budget. So we've heard that it's because denials have been increasing, it's been leaving less room, less financial room for other things that the hospitals used to have more room to prioritize. We don't have an exact number for you today to say it's this percent or it's this many dollars, but certainly there's certainly the increase has been substantial. From 19 to 24, we mentioned it was a 47% increase in total denial dollars. It's even bigger if you start in 21, since actually 21 had a lower starting point than 19. But we've heard from many members that it's, denials are making it harder for them to meet their GBR targets in a multitude of ways.
Thanks, Brian.
Yeah, I think that's an important, point. I think as we're progressing into the AHEAD model with, more, with higher requirements to generate total cost of care savings for Medicare, it's just going to be an environment where we're going to confront a more resource constraints for hospitals. And so this is one reason why we want to make sure, that we're addressing problem denials and really mitigating just the amount of resources that hospitals have to devote to manage the denials that they're confronting. I mean, I think, what I think we hear a lot about from our members, there's a lot of interest in the increase in denials that they're seeing for Medicare Advantage. For example, we've got a new program that we're launching to provide support to these plans, but we'd want to make sure that plans that are qualifying for support are meeting reasonable benchmarks for denials and that they're not outliers. I think another thing is that this isn't, directly within the scope of the adverse decisions focus, but just authorization for post-acute services. When you've got a commercial or Medicare Advantage payer, is becoming an increasing area of concern for hospitals, specifically as we're working to discharge folks in a timely manner and support throughput. And so I think that's one area I'd flag, just to talk about some of the emerging trends. And then finally, for the Medicaid denials, that, they're persistently high. And I think one emerging front of challenge with Medicaid denials includes audits, increasing scope and size of audits that are pulling in more claims, potentially through the use of AI technology. We've got audits that are no longer time bound. They're prepay audits, and it's in some cases have some challenging time frames to respond. And so I think one area that I think would be of interest is just to have I think more of a fuller understanding or line of sight into the utilization review standards, the audit standards that are applicable to MCOs and the third-party vendors that are used, just to make sure that we have some standard reasonable procedures there. So I hope that's a little helpful to sort of speak to some of the comments that we're receiving from some of our members, just to give a little bit of color to some of this data, how it's being viewed.
Patrick, thank you. I do have a question. Does the HSCRC data allow you to break out denial rates for FQHC affiliated claims versus hospital-owned outpatient settings?
Yeah, I don't think it does. I have to double check that, but I don't believe we have that level of granularity in the current data that's being collected. That might be one of the metrics that they're considering adding in their increase going forward. But at the current level, we really can only break out inpatient, outpatient, and emergency at those broad levels. And we don't have much more granularity after that.
Okay. Brian and Patrick, I don't see any other questions. I want to thank you both for your presentation and for the work that you're doing. I think the data is really going to help us going forward as we, try to get solutions with this work group. So I appreciate both of you. I'm going to turn this over to Commissioner Grant, who's going to talk to us about our next steps.
Great. Thanks so much, Madam Chair. Craig, is it possible for you to share the draft work plan document?
Yes, I will share that now.
Awesome. Thank you so much. So we put together, just for reaction, nothing set in stone, a draft work plan. And just to remind us and ground us all, the first page of the draft has the charges that have been set forth for us in legislation. So there's some data in questions, including the number of adverse decisions compared to claims, number of enrollees in each health plan, diagnostic and procedure information on adverse decisions, and any other data used to inform the work group's goal. And then our charge is to make recommendations to improve state reporting on adverse decisions, including recommendations regarding standardized definitions of medical service categories, health settings, adverse decisions, and medical necessity. Standardized method for categorizing adverse decisions and prior authorization denials, and a standardized process for reporting grievances or filing complaints and appealing adverse decisions. The work group's also charged with developing strategies for and making recommendations to reduce the number of adverse decisions, and developing recommendations for legislation to address the rise in adverse decisions and standardized state reporting requirements regarding adverse decisions for all payers. And then we've requested an extension of the deadline of that report to December 1. Next page. Thanks, Craig. So this is just a bit of where we've been. We had our first meeting back in November. We submitted an interim letter in December, and we've just gone through a couple of great presentations today, and we're discussing our work plan. Next page. So we've and I think there have been a lot of questions today and comments about, I think, Medicaid, right? And what we're seeing about Medicaid and Medicaid specific procedures. So we definitely need to hear from the Medicaid team. Dr. Dixon, we've penciled you in tentatively for June, but hope the Medicaid team can present to this group. And then tentatively, we have penciled in, I know Dr. Jacobs has a wealth of knowledge about Medicare Advantage policy and any data that might be at the available at the federal level. And so could talk to us hopefully in May about what's happening in the Medicare space and rules. Obviously, we can't legislate on Medicare, but I think it would be helpful for us to understand what's going on in that space to help inform our work if we're trying to get to more of a standardized place. We also have a placeholder in the June meeting for any stakeholder presentations. I will say again, we could think about building those in to May as well. And I know that our team is really interested from hearing from work group members and the public. What do we need to hear about that we haven't yet? What are the perspectives that we're missing? What is the data that we're missing? We'd really, really, really like to understand that, make sure that we build those presentations in as early as possible to our work this year. For our July meeting, we're thinking about analyzing what we've talked about so far about plans and to discuss potential recommendations for standardizing, as well as brainstorming recommendations for legislation that could be incorporated. Next page. So this page really reflects the timeline that we need to follow, this page and the following, to get to a December 1 submission date. We're anticipating that we would need to get consensus around or have discussion around recommendations by that August meeting. Then our agency staff could take that back, work on a draft, with the chair, get that draft out to all of you to review and comment on in early October, and then have a public comment session and come back. Next page. So with the hope that we would be finalizing a report in early November, because once we finalize a report as a work group, there is a state process that any state report needs to go through in terms of review and approval. And this would give us plenty of adequate time to do that so we could meet our December 1st deadline. So Craig, you can go ahead and stop sharing. I guess our thought was as well, Madam Chair and work group members, that we would share this draft work plan with you, have a discussion today, but also accept any comments in to Riley Williams, who's staff for the work group, so that we could present a final work plan at our next meeting that we would be running with. And with that, happy to open up to any questions or comments.
I see Zach has a question or comment. Zach?
Just on the stakeholder presentations, I think it'd be helpful to hear more directly from the community of payers. So from the League of Life and Health Insurers, MCO Association, whatever it may be. I think that'd be a helpful context in those stakeholder groups.
Thanks, Zach. Absolutely.
Maria, I see a comment in the chat related to Medicare Advantage. Since this came up, CMS has an equivalent complaint tracking form related to prior authorization in case it's useful, and the link is there.
Oh.
So I think maybe you or Riley might want to look at that.
Yeah, great. Thanks. Doug, did you want to talk about that?
Sure. I just briefly mentioned this is related to the MIA tracks the complaints in Maryland. As Commissioner Grant had said, we can't exactly legislate related to Medicare Advantage. Medicare Advantage has their own complaint tracking module for elements inclusive of prior authorization in other areas. And so I provided that link, and to the extent that there are Medicare Advantage related prior authorization issues that folks want to make call to CMS's attention, we can share the link.
Maria, I think the work plan, it's pretty intense, but I know, we have a deadline, and so we really need to try to get this done by December in case there's legislation needed for next year. So I don't really have any additional comments. Does anyone else want to comment, add anything? Discuss the work plan? I don't see anything.
Madam Chair, just one more thing, just if I may,
Sure.
a question about the definition that we're going to be using moving forward. I've heard a presentation today about adverse decisions that was done by Mr. Butler. It was very clear. I understood it. But I also had a presentation, an excellent presentation from the MHA, and it was talking about denials. What realm are we working within? Is it the definition from Mr. Butler of adverse decisions, which is backed by statute? Is that the one that we are talking about here?
Maria, I'm going to ask you to comment on that because I had the same question, but thank you, John.
Yeah. So I'll tell you how I'm thinking about it. I think it's an excellent question. And I'm sure other members of the work group might have a perspective too. I think at a base level, we need to focus on adverse decisions and medical necessity. I do think that's the charge in the work group's plan. But I also, I hear and see, for example, from the MHA presentation, I think from other providers, I know we've just had a big discussion on downcoding, right, in the session. It is not just the adverse decisions that are resulting in denials that, I think there are questions on. So I guess my recommendation would be to focus in on adverse decisions, but I think the broader world of denials is certainly coming up, and I don't think that we can ignore that in our discussions and reporting.
Right, does that answer your question?
I think it's helpful, yes.
Thank you. I don't see any other comments right now. So Marie, will we, is our next charge to figure out the next dates, or you're going to send out dates to us for the next meeting?
Yeah. So I think what our team will do is work with your schedule, Chair Vital, and I think to the extent that we can, work group members, and get meetings on the calendar for the remainder of the year. And we'll do that now so everyone has plenty of advance notice. But our next meeting, no date set yet, but is intended to be in early May. So
thank you. Marie, do you have any other comments before we conclude the meeting? You or Dr. Crom, before we close out?
I just want to thank everyone for their engagement. Want to encourage folks to take a second to review the draft work plan and get back to us with any suggestions on presentations and review. We want to hear from everyone on this issue and take it very seriously. But I'm grateful again to you, Madam Chair, for taking on this role. I'm so deeply appreciative. So thank you.
Thank you. It's very interesting, actually. I think it's we're going to learn a lot over the next few months. So I appreciate the work that you and Riley and your team are doing, Marie. Thank you. Dr. Crom, John Crom, do you have anything you want to add?
Just to add to the appreciation that Commissioner Grant just provided, and appreciation to you, Madam Chair.
Thank you. If we have no other comments, that'll end the meeting for today. And thank you all for your attendance and your work on this important issue.